Hello, this is Eric Strong again, and today I will be discussing the often overlooked acid-base topic of mixed disorders with normal pH. The learning objectives of this lecture is simply to be able to recognize and identify these easy-to-miss pathologic states. Sometimes a student who is first learning how to interpret an ABG can be confused as to how a patient could have multiple acid-base disorders but still end up with a normal pH. This simple wooden balance scale, which I introduced in the last lecture, will represent the state of a person's pH. When it's nice and level, the pH is 7.40. When it tips to the left, it will indicate acidemia, and when it tips to the right, it will indicate alkalemia. Suppose for a moment that a patient starting with normal pH develops a mild, isolated metabolic alkalosis. This will necessarily cause the scale to tip into alkalemic territory. If that person then develops a severe respiratory acidosis, the scale will tip in the other direction. The patient will have an acidemia despite the metabolic alkalosis, provided that the respiratory acidosis has a greater impact on the pH. We've already looked at numerous such situations before, starting in Lecture 4, when I first introduced the concept of mixed disorders. The situation we are trying to identify today is when multiple acid-base disorders all balance out and leave the patient with a normal pH. There are 7 such scenarios that can be diagnosed from an ABG. I certainly do not expect anyone to be able to recite these off as a list from memory, but with experience, you should be able to reconstruct this list from deduction. I'll run through them quickly. First, equal parts respiratory acidosis and metabolic alkalosis. Next, a small respiratory acidosis and a small elevated gap metabolic acidosis, which together balance a large metabolic alkalosis. A metabolic acidosis and a similar sized respiratory alkalosis. The metabolic acidosis can be an elevated gap, a normal gap, or even smaller versions of both together. There can be a large elevated gap metabolic acidosis, which balances with small metabolic and respiratory alkaloses. Finally, an elevated gap metabolic acidosis can balance with a metabolic alkalosis. It's important to point out that just because two acid-base processes are balancing each other out with respect to the pH doesn't mean that they share similar importance in the patient's overall condition, nor does it mean that there is equal urgency to address each. For example, I can imagine a situation where a patient has a lactic acidosis from septic shock that happens to perfectly balance, in terms of pH, his metabolic alkalosis from milk alkali syndrome. However, treatment of septic shock would certainly take priority over treatment of the latter problem. Here is a chart that summarizes the PCO2, bicarb, and anion gap for the mixed disorders that we just saw can result in normal pH. If a patient has a normal pH but also a high PCO2, high bicarb, and normal anion gap, a respiratory acidosis and a metabolic alkalosis must both be present. If the pH is normal and the PCO2, bicarb, and anion gap are all elevated, the patient must have the triple disorder of a respiratory acidosis, a metabolic alkalosis, and an elevated gap metabolic acidosis. If the PCO2 and bicarb are both low and anion gap normal, the only explanation is a respiratory alkalosis combined with a normal gap metabolic acidosis. If we have the same situation except that the anion gap is high, then the combination is a respiratory alkalosis and an elevated gap metabolic acidosis, plus or minus another metabolic disorder, either an alkalosis or a normal gap acidosis, which we can distinguish from the delta ratio. Finally, if both the PCO2 and bicarb are normal, but the anion gap is high, the patient must have an elevated gap metabolic acidosis and a metabolic alkalosis. There is no other explanation. As I said earlier, I certainly would not expect anyone to memorize this chart, but with time and practice, you will be able to reconstruct it on your own. It's important to realize that there are 2 situations that are literally impossible to diagnose from the ABG when they result in a normal pH. These are essentially combinations that will leave the PCO2, bicarb, and the anion gap all normal. First is a normal gap metabolic acidosis balanced with a metabolic alkalosis. The second is a respiratory acidosis balanced with a respiratory alkalosis. You might ask, under what circumstances would this matter? After all, if a patient had simultaneous processes, one of which resulted in hyperventilation and one of which resulted in hypoventilation, and they both more or less canceled each other out, why is that a problem that we need to look for? Well, there are two reasons to be concerned about the inability to conclusively diagnose these combinations. Imagine for a moment that this particular pair of disorders, the respiratory acidosis and respiratory alkalosis, are due in a specific patient to an exacerbation of COPD and an acute pulmonary embolism, respectively. Chances are reduced that these diagnoses will be recognized if the patient's ABG lacks the characteristic pattern that typically accompanies each. Even if they are recognized, their severity may be underappreciated, as severity of these conditions is determined in part by the arterial pH. The second reason to be concerned about this situation is the consequences of when one of the two disorders is treated and that specific acid-base disturbance is fixed. Let's suppose, for example, that we give this patient albuterol and steroids and relieve their airflow obstruction from the COPD. With COPD's effect gone, the patient may develop a clinically relevant alkalemia that we were neither expecting nor prepared for. Finally, one last point if we go back to a perfect balance between a respiratory acidosis and alkalosis. Remember, the acid-base status will look normal in this situation, and these processes will be invisible on the ABG. If this patient were to develop a concurrent metabolic disorder, the pH will no longer be normal. However, the acid-base components of the respiratory problems will still be invisible, and it will look as if the only process present is the one that disturbed the balance. So let's go through three examples. Example number one, a 61-year-old morbidly obese man with COPD and a CHF has an ABG and metabolic panel checked during routine pulmonary function tests. We can see that the pH is normal, but the PCO2 and bicarb are definitely not. The easiest thing to do is to pull up our chart from earlier. This man's PCO2 and bicarb are both high, and the anion gap is normal. Therefore, he must have a respiratory acidosis and a metabolic alkalosis. If we didn't have this chart handy, however, we can actually reach the same conclusion with a small adjustment to the typical approach that I've introduced over the past several lectures. So step 1, check the pH, which we already have said is normal. Step 2, check the PCO2. It's elevated. Usually we would need to know in what direction the pH was deranged in order to interpret the significance of the PCO2. However, when the pH is normal, a high PCO2 means the patient has a respiratory acidosis and is hypoventilating, while a low PCO2 means the patient has a respiratory alkalosis and is hyperventilating. Therefore, this patient has a respiratory acidosis. Step 3. Evaluate compensation. As I've said in previous lectures, compensation for any acid-base disorder will tend to mitigate changes in pH, but it will not bring the pH back to normal. So there really isn't compensation to evaluate here per se, but rather the identification of the balancing disorder. If we know there is definitely a respiratory acidosis, in order to be left with a normal pH, there must be a primary disorder that is the complete opposite. Therefore, this patient also has a metabolic alkalosis. Step 4, calculate the anion gap. 133 minus 92 and 34 is 7. Therefore, a concurrent elevated gap acidosis is not present. Step 5, the calculation of the delta ratio doesn't apply since the anion gap was normal. Thus, we reach the same conclusion that this patient has a respiratory acidosis and a metabolic alkalosis. Two disorders whose effects on the pH perfectly balance one another out of sheer coincidence. What could be the etiologies of these disorders? Based on the very limited information provided, since the patient doesn't appear acutely ill, these etiologies must be chronic in nature. In this case, I would speculate COPD is leading to the respiratory acidosis, and diuretic use for the CHF is leading to the metabolic alkalosis. Example 2. A 14-year-old girl with bulimia is brought to the ER after being found unresponsive at home with an empty pill bottle nearby. Once again, we can pull up our chart of mixed disorders with overall normal pH. In this case, the girl has a low PCO2, a low bicarb, and a high anion gap. This puts us into this category, which unfortunately doesn't by itself provide a conclusive list of acid-base disorders, as there is still the unanswered question of the plus-minus other metabolic disorder. So let's go through this case with the standard algorithm. Of course, pH is normal. The PCO2 is low. As discussed with the last example, when the pH is normal and the PCO2 is low, the patient must have a respiratory alkalosis. Step 3 is evaluation of compensation. Again, this isn't actually compensation when the pH is normal, but more a step in which we identify the opposite primary disorder. The opposite of a respiratory alkalosis is a metabolic acidosis. So far, so good. Step 4 is to calculate the anion gap. 139 minus 88 and 13 is a very severe and impressive 38. Therefore, this girl definitely has an elevated gap metabolic acidosis. Next is step 5, calculate the delta ratio. If you remember from the last lecture, the delta ratio is calculated as the difference between the calculated anion gap and the normal anion gap, divided by the difference between the normal bicarb and the measured bicarb. The calculated anion gap of 38 minus the normal gap of 12 is 26. The normal bicarb of 24 minus 13 is 11. Thus, the delta ratio is about 2.2. Since the delta ratio is above 2, irrespective of the etiology of the anion gap, there is also a metabolic alkalosis. Therefore, in summary, this patient has a respiratory alkalosis, an elevated gap metabolic acidosis, and a metabolic alkalosis. What specific etiologies could cause this? I always like to start with the least common or most unexpected finding. The vast majority of toxic ingestions result in a respiratory acidosis, not an alkalosis. Whenever I hear about a respiratory alkalosis in the setting of ingestion, I think about two things. First, did this patient aspirate on vomit and now has hypoxia-induced hyperventilation? Or second, did this patient ingest aspirin? Aspirin directly activates the medullary respiratory center, leading to hyperventilation when the ingested dose is extremely high. I'd say this latter possibility is more likely since aspirin toxicity can also lead to uncoupling of oxidative phosphorylation in mitochondria, leading to a lactic acidosis, which could be the cause of the elevated gap metabolic acidosis the patient also has. Finally, as the girl has bulimia, she may habitually induce herself to vomit, leading to a loss of hydrogen ions in the expelled gastric fluids. These are, of course, presumptive diagnoses that we would definitely want confirmed with serum drug and lactate levels, along with the urine pH, and she should also get a chest x-ray to rule out aspiration. However, based on the available information, this seems to be the most likely combination of diagnoses that could have led to this specific ABG in this circumstance. Last, example number 3. A 32-year-old pregnant woman comes to the ER with 4 days of nonstop vomiting. Vitals on admission: temperature 37.0, heart rate 145, blood pressure 78/42. This example is interesting because the patient has a normal pH, normal PCO2, and a normal bicarb. From her ABG, it doesn't appear that she has any metabolic problems at all, and it would be easy to miss what's actually going on here. But let's take a close look at her chemistry panel. Aside from the elevated creatinine and low potassium, her anion gap is 146 minus 92 and 26, which is 28. So how is it possible to have such an elevated anion gap but completely normal looking ABG? If we pull up our chart one last time, we see that this combination of findings occurs in the last row, which is indicative of the combination of an elevated gap acidosis and a metabolic alkalosis. What if we use the standard algorithm? Well, pH is normal, PCO2 is normal. Evaluating compensation makes even less sense here than it did in the previous two examples, since steps 1 and 2 are normal. Step 4, we already calculated the anion gap to be 28, a high enough elevation that it can only be explained by the presence of an elevated gap acidosis. Finally, step 5, calculate the delta ratio. The delta anion gap is 28 minus 12, which is 16. That's easy. What about the delta bicarb? The delta bicarb, to remind you just once more, is the normal bicarb minus the measured bicarb. The normal is 24, the measured is 26. So therefore, the delta bicarb is actually negative 2. So this makes the delta ratio technically negative 8. My guess is, even if you have a fair amount of familiarity with using the delta ratio to diagnose mixed metabolic disorders, as reviewed in Lecture 6, you have probably never come across or thought about the possibility of a negative ratio. What does it mean? I'm going to take a very brief digression here to mention the two situations which result in an elevated anion gap and a negative delta ratio, which is not limited to patients with normal pHs. First, the combination of an elevated gap acidosis and a metabolic alkalosis can do this. In this circumstance, the pH will either be normal or high. Second, the combination of an elevated gap metabolic acidosis and a chronic respiratory acidosis, in which case the pH will be low and is in fact usually very low. This reminds me actually of a more general point that I should have made in the last lecture, that the delta ratio is not really valid for investigating acute metabolic disorders in the presence of severe chronic respiratory disorders, as these patients will have abnormal baseline bicarb levels as a result of metabolic compensation. So if we go back to this case, a negative delta ratio with a normal pH and no evidence to suggest a severe chronic respiratory disorder, this patient must also have a metabolic alkalosis. So in summary, she has an elevated gap metabolic acidosis and a metabolic alkalosis. Both problems would have been missed had the anion gap not been checked, as the ABG was normal. The likely etiologies here: her vitals suggest that she is in shock, probably hypovolemic shock from an inability to keep down any oral fluids. Shock of any cause leads to poor end organ perfusion and the development of lactic acidosis. The metabolic alkalosis is likely due to a combination of loss of hydrogen with vomiting and a contraction alkalosis from volume depletion. So that's it for this lecture on mixed acid-base disorders with normal pH. Please don't worry if you struggled with these examples, as they are among the most difficult acid-base problems you'll ever likely encounter on the wards. This also concludes the subset of lectures within this course that have provided the roadmap for diagnosing acid-base disorders. In the next subset of lectures, I will discuss in more detail the differential diagnosis of the various metabolic and respiratory disorders. This will allow us to move from identifying a patient's pathophysiologic state to a more specific etiologic diagnosis that can more specifically direct treatment.